Wait.
She will tell.
Okay, we are live now. See you start.
A warm welcome to all of you for the ExRxIndia presenting for the students by the students webinar series. First of all, I need to thank ExRx founder Dr. Chandramohan sir and Sri Samraj Health Service Private Limited CEO Mr. Sampath Kumar sir for their continuous support and day and night services for webinar. So secondly, I need to thank our technical coordinator Professor Duna Saha ma'am for her tireless hard work and continuous support for a physiotherapist by a computer science engineer. So I need to thank all the physiotherapy graduates for the supporting and contributing to our for the students by the students webinar series. This program is not a competition, but this is to bring out to build your confidence for public speaking. So this is Dr. Rupesh from Peak Health Studio, Chennai. Today's 8th topic for the day is presented by Harshitha Dhruv, and she can take up the session. You can start.
I'll share my screen.
Shweta, please share your screen. Yeah.
Is it visible to everyone?
Go to full screen.
Yes. Okay, so hello everyone, good morning and welcome to this webinar. Thank you so much, Dr. Chandramohan sir, Dr. Rupesh sir and Luna ma'am for giving me this opportunity. So my topic for today is Duchenne's muscular dystrophy, and DMD is Duchenne's muscular dystrophy is X-linked. So today for the objectives are to cover the introduction, the basic clinical signs and symptoms of the condition. What are the functional transitions that we see in a patient of DMD when a patient comes to the OPD with this condition with some complaints? What are the signs and symptoms that they come with? What are their complaints and how do we manage it? So what is DMD? DMD is a type of muscular dystrophy. There are various types of muscular dystrophies, including X-linked recessive, autosomal dominant, and even congenital. DMD is one of the most commonly seen muscular dystrophies, and it is the most severe type of muscular dystrophies. Becker's dystrophy is another type of X-linked muscle dystrophy, which is a milder version of DMD. You can say it is a milder version of DMD. And the life expectancy is much more in Becker's than in DMD. So DMD is a X-linked recessive disorder where there is an error in the gene XP21, which encodes for dystrophin. Dystrophin is also found in the cardiac muscles, and usually children who are affected with DMD also have conditions, cardiac problems like cardiomyopathy and other cardiac issues. DMD is only seen in boys as it is an X-linked recessive disorder, and the females are the carriers and the males are the sufferers. So the family history matters the most while diagnosing DMD. If there is history of a maternal uncle or a maternal cousin who is suffering from such condition, then it's a very strong indication to think about DMD while investigating. DMD is an element type of lesion and it affects the muscles. The muscles are more affected and it starts proximally, and the weakness of the muscle starts proximally. It is a symmetrical disease, so both the sides are affected equally. These children have a very short lifespan of roughly 20-25 years, and they stop ambulating around 10 to 12 years of age. What are the clinical signs and symptoms that we see in a patient of DMD? The signs and symptoms appear grossly around the age of 5, but we can still notice them from birth as it is a congenital, means it's seen from the start. The creatinine and kinase levels are elevated more than 100 times in the early stages in the child. It is the only sign which is evident at birth. It is the only indication that the baby might have DMD, apart from the genetic history. Other than that, EMG studies are conducted along with muscle biopsy, but these are conducted at a later stage when we are more sure of the disease. To finalize, to confirm our diagnosis. Other than that, these kids may present with developmental delays while growing up. They may start walking late. They may have difficulty in crawling, getting up, climbing up the stairs. These kids will also fall very frequently. They won't be able to run fast. And even some of them have a waddling type of gait in the start, so with a wider base of support. So these signs are quite prominent, and these complaints are what patients' parents usually come to us with, that the baby is falling frequently, he walks differently, and all those things. So how do we diagnose it, and how do we move ahead? Gover's sign. Gover's sign is a very typical indicator of DMD. In this, the baby, since he has muscle weakness, he is unable to get up from the floor on his own. So he tries to climb up on his own body to get up from the floor. So it is a very early and distinctive feature of DMD. When the child is starting to stand up, he will try to crawl on top of his own body. As you can see in the picture, he'll first try take the support of the floor, then he'll put his hands on his knee, and then slowly he will get up. And Gover sign is a sign which is not classical to DMD. Means, why does the child does this specific pattern of getting up? Because he has hip extensor weakness and quadriceps weakness, which makes him unable to get up from the floor on his own. So Gover's sign is also seen in some neuropathies and other muscle dystrophies, where there will be a similar presentation of quadriceps weakness and hip extensor weakness. Next is the Marion sign. Marion sign, due to the proximal muscle weakness, the pelvic girdle and the shoulder girdle specifically are weak, the muscles around them. So the child, when we try to lift the child up from the around the arm, under the shoulders, the child will slip from our hands due to there being no muscle strength or muscle tone in the child's arms. So the child will slip from the examiner's grip as the child is being lifted from under the shoulders due to the reduced muscle strength. What are the functional transitions that we see? Initially, the baby will present with some proximal muscle weakness and a waddling type of gait, but he'll still be able to walk on his own in the initial stages. But slowly, as the child grows up, he'll be able to ascend and descend the stairs on his own initially. He'll have a few falls, but still he would be able to do it. As the age progresses, the muscle becomes more fibrotic and there is atrophy, and a lot of the child is not able to do these activities on his own anymore. So apart from this, there are a few typical postural changes which are seen, such as increased lordosis. There is hyperlordotic posture, and to compensate for it, the shoulders go into retraction because the child wants to maintain his COG within his base of support. So he will try to avoid the risk of fall. So he will go into shoulder retraction, but the lumbar will go into hyperlordosis, which will also cause hyperextension at the knee joint and will make the child go on to the toes to compensate for the hyperextension of the knee joint. This will also affect the biomechanics, and later, which if there is increased plantar flexion, the child can go into buckling and can fall down. So after this, to avoid all this, we'll see in management how we can prescribe orthoses and other devices to assist the child to walk in walking and everything. So yes, the child is able to ascend and descend in the early stages. After that, there is moderate lordosis, which is seen. The child is unable to run and has a bit difficulty with the steps, but he's able to climb the steps. As it progresses, the child becomes unable to climb the stairs as well, and much more waddling is prominent due to the hip abductor and quadriceps weakness. Ambulations require assistance of orthosis and external supports like the walker or some or different types of orthosis like knee bracing and everything to assist in walking. In the later stages, the child stops ambulating completely and becomes wheelchair bound. So it is essential for us that we make sure that the ambulation goes on for as long as possible, because for functional use, our aim is to make sure that the child can have functional mobility for as long as possible. It is a degenerative disorder, so we cannot do much to improve his condition per se, but we can improve his life, the way he lives. We can improve the duration for which he walks, and we can improve the quality of muscles and delay the condition for as long as possible. So we'll move on to the management. The short-term goals for the management. In the initial stages, first and foremost comes patient education and the family education. It is a condition which is degenerative, and the life expectancy is not much. So the family needs to be prepared, and they should know about the condition, that in this patient the child won't be able to walk after a certain point, and he has a low life expectancy. And also, apart from that, the family needs to be prepared. They will need to do a lot of physiotherapy apart from what we do in the clinic. They will have to assist him at night with the orthosis and other stretching and everything to avoid contractures. So patient and family education is the foremost in this. Stretching is the next very important management that we do. Stretching is very important for maintaining the muscle, avoiding the contractures for as long as possible. Initially, we will stretch the muscles to avoid the contractures, and in the later stages, the contractures are going to be there, but we'll delay its onset for as long as possible, and then once the contractures are there, we'll stretch them for better mobility. Night splints are advised to prevent the formation of these contractures as well. When the baby goes into night, there are some splints specifically. The night splint is a kind of a full knee length brace. It starts from the inferior gluteal line and will extend up till the foot. There will be a foot plate which will be placed at 90 degrees to the splint for the foot to rest on it, so that the foot does not, so that the foot is in neutral. This splint will keep the leg into extension and will avoid prevention of contractures. Apart from this, there are some positioning advices which we can give to avoid contractures. Example, if we ask the patient to sleep in prone, so sleeping in prone will avoid contractures of the quadriceps and iliopsoas. It will assist in stretching as well. And these night splints are advised. Apart from that, sub-maximal strength training is done. These children need to have these. We do not give full strength resistance strength training, as we do not want to put a lot of load on the muscles, but some load on the muscles is necessary to maintain the properties for as long as possible. And with submaximal strength training, we can do that, and this will also help in getting them to walk more and all those things. It will assist them to hold the walker in the later stages and everything. After that, submaximal strength training, we'll do active exercises for as long as the patient is able to do. After that, active assisted and resisted submaximal with not full strength, but 50% or 20% of our strength. And also after that, we can move on to passive training when the child is completely wheelchair bound. Also, all these exercises need to be formed in the form of games and activities, as we need to remember these kids are really small and we need to keep the child engaged and active. If we ask him to lift the hand up 10 times, he'll get bored. So what we can do is we can engage the child by forming games and creative stuff like this. Like we can pass the ball, we can do a bowling kind of a setup and ask the child to kick the ball and drop the cones or the bottles, or we can do passing the parcel or reach outs and all those kind of things. So the child is also more engaged in the activity and he'll also have fun and he'll want to participate in the exercises as well. Maintaining the spinal alignment in order to avoid postural issues is also very important, as these children tend to go into hyperlordosis and also scoliosis in the later stages. Due to improper positioning or due to the muscle weakness, they may go into scoliosis as well. So there are some spinal jackets also which we can prescribe to the patient if possible to avoid these kind of changes. Long-term management, our aim is to prolong ambulation for as long as possible. So as we said, we'll do stretching, we'll do subpar maximal strength training, and we'll try to prolong the patient's ambulation for as long as possible. Apart from that, we can give some bracing and some orthosis to help the child more. A knee brace is really advisable when the patient starts going into extreme plantar flexion. A knee brace will support the knee and will avoid it going into hyperextension, which will also help to reduce the plantar flexion a bit. So the quadriceps, the knees won't buckle down in that case. It is true that since the child won't be able to flex the knee a lot in this condition, the child will go into a circumduction type of a gait because of this, which will be more energy consuming for the child. But it's still better than the child falling down and losing confidence. So that is an important aspect which we can do for ambulation. We can use assistive devices such as walker. Crutches are not advisable since the child has shoulder girdle muscle weakness. So it will be difficult for the child to hold the crutches and move them properly. But a walker with wheels can be advised. With wheels, because it's easy to push the walker in front than lifting it up and placing it ahead. So that can be advised, and constant monitoring is required by the child is a walker with wheels, especially because he may just push it and fall. So that's also an important aspect that we need to keep in mind. Apart from that, prescription of appropriate splints and orthosis for the same, for prolonging the ambulation, and the night splint and all those things. Preventing the child from getting obese. This is also a very important part in patient education, as these children, due to the lack of physical activity according to their age demands, the child tends to get obese. So it is very important that we make sure that the child does not get obese, because it will again lead to difficulty for the child himself, as he will get as the muscles are not that strong, the muscles will have to bear more weight if the child gets obese, and we need to prevent obesity and other consequences which comes with obesity. So the parents need to be advised and told that obesity should be avoided for as long as possible. Giving healthy and low fat and high fiber diet is very necessary. So the nutritional aspect is also very important. Apart from that, since the contractures will be formed, we cannot, it's inevitable in the later stages. We will do stretching for them, all the passive stretches for all the muscles, the hamstrings, the quadriceps, TA, pectorals, biceps. It's necessary to maintain the mobility for as long as possible. Ensuring clear airway and maintaining proper respiratory hygiene. This is a very important factor in the later stages, because apart from the muscular problems, these children usually succumb to respiratory infections because of their inability to cough and huff so properly. So these children may have respiratory infections. So we have to ensure that the respiratory airways are maintained, proper respiratory hygiene is looked into, We can teach them huffing and coughing for as long as possible. They can do it. ACBT can be done for them. Removal of the secretions if there are any. Apart from that in the later stages when the child is unable to cough and huff on his own, there are suctioning methods which can be done to remove the cough. The respiratory airway should be kept clear, so that there is no chance of any respiratory infection. In the later stages, when the child is wheelchair bound, we need to make sure that there are wheelchair bound or bed bound, there are no bed sores that can occur. So the basic bed sore prevention, keeping that the pressure points dry, clean, and also making sure to change the patient's position every 30 minutes, 30 minutes to 1 hour, so that there are reduced chances of bed sores and also other complications which are associated with immobilization, prolonged immobilization for so long. Apart from that, when the child is wheelchair bound, we may need to make some modifications in the wheelchair depending on the child's need. We have to make sure that he sits with a 90-90 angle of the hip, knee, and ankle so that he's comfortable. It should not be, his leg should not be dangling because he cannot support it on his own. There should be a belt on the wheelchair to make sure that he does not flop down or move sideways. So all these modifications are also required in the later stages. So thank you everyone for patiently listening to me. I hope I covered it all.
That's nice, Harshitha.
Thank you, ma'am.
Yeah, very brief session and outline on different signs that DMD faces. You have explained very well.
Thank you, sir.
Chandramohan sir.
Yes, nice presentation only. Sorry, I was having breakfast. Nice presentation, Harshitha. Thank you for the informative session. And I thank your principal. Which college? I forgot to collect.
College of Physiotherapy.
Yeah, thank you. Thanks for your principal, vice principal, and the professors for supporting you and your friends also. And thanks to ExRxIndia. Thanks to ExRx team members. And thank you all the participants for continuous support actually. From morning we are killing you. So thanks for that support and cooperation. We will meet in a very good topic with you, Harshitha. I hope you will present again for us.
Yes, sir, definitely. Thank you so much for giving me this opportunity, and it has really helped me also to increase my confidence a lot. And also all the webinars that you've been conducting in this lockdown, it's amazing and it has made us grow a lot. Thank you all.
Thank you. You are having a lot of appreciation from the chat box also. Thank you so much. Bye-bye. Join with us till the evening.